Welcome to this video. Today we're going to be talking about angina. What is angina? So angina is essentially when you have some atherosclerosis. And what is atherosclerosis? Essentially fatty plaques which build up in your arteries, and that affects the blood supply to the heart, which causes myocardial ischemia. And myocardial meaning heart muscles, and ischemia meaning lack of oxygen, which causes your angina pain. So first of all, what are the risk factors of angina? So we can write the risk factors here. So risk factors, we can break them down into modifiable and non-modifiable risk factors. So in terms of the modifiable risk factors, these are things that we can change. So people can often change and control their blood pressure. People can control their weight. So obesity is a risk factor. People can control their sort of diabetes, their cholesterol, and also if they're smoking, they can stop that as well. Non-modifiable risk factors include things like your age, your gender, your family history, and your genetics. So these are important risk factors to be aware of when you're seeing a patient who may be complaining of angina. So if we go on to the classification, so there are a few different types of angina. The first one is stable angina. So stable angina. This is essentially when you have on exertion. So on exertion. Number two is when you have unstable angina. This is more worrying. This is when you have it at rest. Three, you can have something called decubitus, which is a bit more rare, but it's when lying down. Number four, you can get something called variant angina or Prinzmetal angina. This is due to coronary artery spasm. So now we know some of the risk factors, we know some of the classifications. What are the actual clinical features of angina? So if you write down clinical features here, number one, you're going to get a central chest pain. So chest pain, of course. Importantly, this is on exertion, and it's improved, so the pain gets better by resting. Okay, you can also get other sort of signs. You can get radiation to your arm or your jaw. You can also get sort of nausea and more sort of worrying signs, nausea, lightheadedness, etc. Other things can bring on angina, so things like, cold weather, eating a heavy meal. These can and have been known to bring on angina. So now we know some of the clinical features. How can we investigate angina? This is easy. We can investigate one by doing an ECG to make sure there's nothing nasty going on. Most cases in angina, you'll have a normal ECG. You can also do some blood tests. So we're looking for causes that may cause the angina, and typically we can do a full blood count. This checks for anemia. We can do thyroid function tests, looking for sort of thyrotoxicosis. So these are ruling out fixable and easy causes. You can also check HbA1c to look for diabetes. And you can also check the lipids to see what their lipid profile is, if they've got hyperlipidemia. We can also then do some specific special tests. So we can do a CT scan, so CT coronary, so of the heart angiography. So this uses CT scan to look at the coronary arteries of the heart to see whether there is any blockage or how serious the blockage is. And they can also do a more invasive one, which is a coronary angiography, so without the CT scan part of it. And this is an invasive process where you actually use dye and x-rays to have a look in real time, the blockage and how the arteries are looking. So that brings us on then to the management of angina. So always important in angina, you need to modify these modifiable risk factors, because if we can fix these, we might be able to fix the angina, or reduce the risk of further worsening of the angina and inevitably, unfortunately, heart attacks. So blood pressure, so we often advise sort of decreased salt in the diets, obesity, so increase your exercise, weight loss. All of these things are really important, and healthy diet. Okay, when we talk about medication wise, if someone's having an acute angina attack, we can give them a GTN spray. So this is a nitrate, and the role of this is to help abort the angina attack, so to stop quickly. And this essentially can be repeated a couple of times. It's a spray. There are some side effects you need to be aware of, and the side effects include it can cause a real nasty headache, which improves as soon as it's stopped or you stop taking it. It can cause low blood pressure as well, so it might be a little lightheaded as well. The rule is usually you want to give this once and then repeat after 5 minutes, and then hopefully this resolves the attack. If you don't have any resolution, then you need to call an ambulance, and that's more of a worrying sign. In terms of the medical management, so we like to use either a beta blocker or a calcium channel blocker. So examples of beta blockers such as metoprolol, bisoprolol, all important, and calcium channel blockers are things like amlodipine. These are non-rate limiting. You can use other calcium channel blockers such as verapamil or diltiazem. Okay, so these are your medical management. If this doesn't work, you move on to the next step, which is when you combine both together. So you can combine your bisoprolol with your amlodipine. Important here to make sure you don't use those rate limiting calcium channel blockers such as verapamil or diltiazem. Why? Because if you give both a beta blocker and these rate limiting calcium channel blockers, that can increase the risk of complete heart block, cause heart failure, and it should not be used. Okay, then the next step after that is, if they're unable to tolerate some of those medications, we can do sort of a potassium channel activator, which is called nicorandil. So you can use nicorandil. And then we say normally you can add a third drug. So third drug if awaiting specialist referral. Okay, so that's essentially the management plan of it. Let's recap. So it's reducing salt, increasing exercise, good diet. You can use a GTN spray, which is sort of a quick fix. Spray it under the tongue, and that should stop an attack. For more longer term and stopping symptoms ongoing, you can use either a beta blocker or a calcium channel blocker. If that doesn't work, then we can use both of them together, remembering not to use the verapamil or the diltiazem with the beta blocker. And then if unable to tolerate some of these medications, you can consider a potassium channel activator such as nicorandil. And then if they're on the maximum dose of a beta blocker, maximum dose of a calcium channel blocker, we can add a third drug if they're awaiting specialist assessment. Whilst they're awaiting specialist assessment, some of the things that they may do are things like PCI, which is percutaneous coronary intervention. This is where they put a catheter, and this catheter uses a balloon to squash the atherosclerosis, or they can use a CABG, which is a coronary artery bypass graft, which is where you bypass the blockage. So if you've got a blockage over here, you essentially get another artery, and you make sure that that artery then can supply from there to there via the bypass, and this blocked artery is not causing the issues. So that's a quick summary on angina. If you have any questions, let me know.